Good morning, everyone. It's 7 o'clock, so let's go ahead and get started. This week's celebration is going to go to Granville Lloyd and Nick Cost and Andy Meacham because just within the past week or two, we've gotten notification from the ACGME that the urology, both the adult and the pediatric training programs received full accreditation for their full cycle. So congratulations to that team that put that all together. Let's thank Trina Schmidt and the education office for all the hard work, because it takes a lot of work to get ready for one of these ACGME site surveys. So this morning we have two faculty speakers. The first to speak this morning is going to be Maria Albuja Cruz, who's going to talk to us about thyroid multidisciplinary collaboration in their cancer clinic. But by way of introduction, she's an associate professor in the GI Trauma and Endocrine Surgery Division. She did her medical degree back in Quito, Ecuador, and then came here in 2006 to do her surgical residency training and an endocrine surgery fellowship, and joined the faculty as an assistant professor in 2012. She currently is the GITES Division Quality Director and also is the practice director for the multi-specialty surgery clinic in the AOP. She's been the co-director of the Thyroid Tumor Board for many years, and she is one of the faculty senate representatives for the Department of Surgery. So she's going to speak to us about multidisciplinary collaboration in thyroid cancer. Thanks, Dr. Albuja Cruz.
Great. Good morning. Good morning. I'm truly excited to share the impact of our thyroid multidisciplinary clinic on the care of our patients with thyroid cancer. This program is the result of a strong, long-standing collaboration between endocrine surgeons, endocrinologists, radiologists, and pathologists. And this partnership has been nurtured at our institution for decades. And I want to say that I'm honored to give voice to the hard work and dedication of every member of our MDC team. The outcomes I will share today reflect the sustained commitment in our department's leadership in multidisciplinary care. The three objectives that will guide our discussion today are: first, we will look at how preoperative disciplinary collaboration directly shapes operative decision-making and helps reducing complication. Second, we will review the post-operative care pathways that have emerged from our coordinated model. And third, we will discuss the institutional barriers that can limit access to this multidisciplinary care. But before we start looking at the numbers, I want to introduce you to a patient who shows why this work matters. Ms. Whitney was a 55-year-old female that came into the emergency department with severe hypertension, weight loss, palpitations, and bone pain. She had a CT scan that showed massive bilateral adrenal tumors, innumerable lung nodules, and widespread lytic bone disease. She was diagnosed at an outside hospital of metastatic pheochromocytoma, and she was started on chemotherapy. But once she entered our multidisciplinary care, everything changed. The team reinterpreted her imaging, and we integrated pieces of the puzzle that have been overlooked before, her hypercalcemia. We obtained a calcitonin level that was over 5,000 and recognized the significance of red mutation that was found on the tissue analysis. Altogether, we made the correct diagnosis and changed it to widely metastatic medullary thyroid cancer. This is a completely different disease requiring a completely different treatment pathway. One visit changed her trajectory because we all looked at her together. This is the human face behind our MDC outcomes. Our MDC brings together the key specialists who shape the thyroid cancer care: endocrine surgeons, endocrinologists, ENT, radiology, pathology. And our MDC, Kenny Sue, is the true backbone of this operation. Since we launched in 2022, we have been holding this conference every week and we see about 14 dedicated thyroid cancers a month. This model reflects what patients consistently ask they like. 90% prefer multidisciplinary decision-making, and patients highly value clear explanations on compassion. In addition, the assistance of navigation through these MDC models improve well-being and coordination. Also, there is significant and strong evidence through a meta-analysis that MDC care reduces mortality in 33% of patients. In addition, our 2025 American Thyroid Association guidelines explicitly call for multi-specialty coordination across diagnosis, disease, radioactive iodine, and survivorship. Our MDC was built around these principles, and the outcomes you will see next reflect that. Here, we are looking at the age distribution of our patients in our thyroid MDC. The median age is 49-year-olds, showed by the dashed red line. The inter-range quartile spans between 37 to 64 years old, which represents the most common age cluster in our population. This distribution shows that thyroid cancer in our MDC predominantly involves young middle-aged adults, but there is a wide range of patients ranging from 18 years old to 94 years old, indicated that this disease happens across the entire adult lifespan. This distribution is relative symmetric, and although we do see older outliers, most of the patients fall within working age population. Understanding these age patterns help us to plan scheduling needs, coordinating disciplinary visits, and also tailor communication and survival strategies for both younger and older patients. Here we can see that the MDC volume had an upward trajectory. We grew from 43 patients in 2022 to 211 patients in 2025. This is almost a 5-fold increase in total volume. This reflects both clinic maturation and the increased referrals into our multidisciplinary model. Next, looking at where these patients are coming from, the out of metro percentage has stayed consistently high. We are about 35 to 45% each year, showing that our clinic continues to serve a large regional population outside the immediate Metro Denver. Also, the out-of-state referrals have grown from 7% to nearly 12% in 2025. Also, signaling that the geographic expansion of this program and the continuation of receiving complex cases from a broad catchment area. The growth reflects expanded provider participation, improvement of patient identification, and also strengthening referral pathways supporting the demand. Here is the clinic diagnosis mix and our PTC trends. About 65% of the encounters that we see during this clinic are malignant. Of those cases that are in the benign or non-malignant category, 31% are indeterminate thyroid nodules. And here is where MDC coordination is really important. Cytopathology review, molecular testing, and shared decision-making prevents non-therapeutic surgery. The graph below shows the PTC cases are trending to more complex cases as the referrals grows, which means more careful nodal staging and preoperative planning. MDC is important in which it helps us giving the right operation and also improves the staging accuracy and provide a guideline concordant care. Here we are looking at our payer mix, and it reveals all the patients' access to this MDC clinic. Our payer mix composition has been remarkably stable. Private insurance consistently reports or represents about 60% of the documented payers, while government payers account for 35 to 40%, with a small but steady proportion of patients with hospital discount program. This stability is important because it shows that the MDC is caring for patients across a broad socioeconomic spectrum, not just those with commercial insurance, but also those relying on Medicare, Medicaid, and institutional financial support. These pager patterns highlight several points. One, that the MDC serves a socioeconomically diverse population. And second, the diversity underscores the importance of navigation support, ensuring the difference in insurance types do not create differences in access to coordinate endocrinology care. Finally, the presence of patient in financial assistance programs remind us that affordability and access remain central to high quality multidisciplinary care. Overall, this slide reinforces that our MDC model is not only clinically impactful, but also equitable and accessible, ensuring that patients receive the same coordinated, guided, concordant evaluation, regardless of their insurance coverage. Across all the slides that were reviewed during MDC conference, 50% resulted in a change in the Bethesda category. The majority of these changes fall into changing from suspicious or parathyroid cancer to parathyroid cancer or suspicious of parathyroid cancer. These changes were about 32% of all changes. And also, the most common change was changing it from atypical undetermined significance category to follicular neoplasm or vice versa. What matters is how often these reclassifications change clinical management. In our MDC, 1 in 4, that means 25% of times they were clinical significance, meaning they directly altered treatment plans. The most impactful category is downgrades to benign, which prevent unnecessary thyroidectomy and avoid exposing patients to operative risk without oncological benefit. Overall, these findings highlight why centralized MDC pathology review matters. It improves diagnosis accuracy, prevents mistriage, and ensures patients receive the right operation or avoid an unnecessary one. This slide demonstrates the impact of the multidisciplinary imaging review within the thyroid MDC. 18.4% of patients have a new finding during their review of the imaging. Out of 105 of these new findings, the largest bar on the graph represents the number that were clinical significant. And that percentage is 68.6%. Nearly 7 out of 10. This visual emphasizes that most of what we find in the MDC imaging review isn't incidental. It's meaningful and actionable. The bars also show the breakdown of these findings. The largest segment corresponds to findings that require another final aspiration, which is the primary driver of changes in surgical planning and staging. Other segment refers discoveries of nodal disease, local advanced features, and findings that ultimately help de-escalate care. Now, what this means clinically. Identifying this finding early allow us to adjust the extent of surgery, improve targeting for FNA, and optimize preoperative staging before the patient ever enters the OR. High-risk features or nodal disease discovered here directly influence the extent of surgery, adjust operative compartments, or pursue additional preoperative workup. Also, it shows the importance of finding no disease, which de-escalate the care. MDC imaging consistently surfaces clinical meaning findings, and 72 out of 105 new findings led to real change in management. This reinforces the coordinated radiology review is essential for accurate staging, right-sizing surgery, and prevent both under and over treatment. This is the overall impact of the MDC. 30.3% of patients that were reviewed in the MDC had treatment plans. 165 plans were changed, and the number needed to discuss was about 3, meaning that for every 3 MDC evaluation, 1 patient has a meaningful change in their care. This quantifies the value in every concrete way. The charts on the slide show that these plan changes are not evenly distributed. They concentrate heavily just in a few critical decisions. The 2 dominant categories is active surveillance and broadening the extent of surgery, which altogether account to 64% of all plan changes. This concentration is important because the decisions determine the extent of surgery, which one is the strongest drivers of thyroid surgical outcomes. Finally, MDC reflects align with published evidence showing diagnosis, staging, and management change in 25 to 30% of the cases across boards. Our 30% management change places us in the high end of thyroid-specific series and mirrors the impact of comprehensive multidisciplinary care clinics. Our MDC drive changes occur exactly where they matter the most, in tailoring the extent of surgery and optimizing the initial treatment strategy, ensuring patients receive the right operation the first time. On this slide, we're looking at how the MDC supports timely, diagnosis-appropriate, and risk-calibrated for patients with thyroid cancer. Starting on the left, the graph shows our high-risk cancer moves through the system the fastest. Poorly differentiated thyroid cancer has a mean time of 19 days, and medullary thyroid cancer averages 37.6 days. These tightly clustered intervals reflect the MDC ability to properly expedite care for aggressive disease. Next, classic PTC, our largest cohort, 184 patients, has a mean of 27 days for MDC treatment. This demonstrates that even with high volume, the MDC maintains sufficient and expected timelines for non-urgent but oncological care. On this slide of the graph, indeterminate thyroid nodules and suspicious nodules take longer, 64 days and 59 days respectively. These cases require additional diagnosis refinements, such as repeat FNA, molecular testing, or interval imaging, so the longer times reflect clinical complexity, not delays. A very small number, like oncocytic thyroid cancer and follicular thyroid cancer, show intervals of 43 to 65 days. Overall, the pattern shows that the MDC is functional exactly as is intended. High-risk cancers are appropriately expedited, PTC care stays efficient despite the high volume, and indeterminate or suspicious nodules receive the careful, stepwise diagnosis workup they need. Across 135 cases that triggered through a hemithyroidectomy, the MDC underestimates the severity of local disease in only 4 patients. That's about 2.9%. These were 3 PTCs or suspicious for PTCs cases and 1 indeterminate thyroid nodule with BRAF mutation. All these patients appear suitable for a hemithyroidectomy based on preoperative imaging and multidisciplinary review. However, during surgery, aggressive features were identified intra-op, and in each case, the operating surgeon appropriately escalated to a broader extent of surgery to ensure oncologic adequacy. These findings highlight 2 component strengths of the MDC model: high overall accuracy, overall 97% of the preoperative staging and pre-op and op recommendation, and the critical importance of real-time surgical judgment, which remains essential for detecting subtle or unexpected disease that may not appear in imaging. In this slide, there is a comparative evaluation of our multidisciplinary clinic relative to the published multidisciplinary care outcomes. In the graph, it summarized this comparison. Our metrics shown on the left demonstrate a 30.3% management change range, which performs at the upper end of published MDC data, which usually range between 15 and 30%. Our MDC detects much higher rates of clinical meaningful findings, and our pathology reclassification, about 15%, aligns with the lower end published for diagnosis stain changing rate. Now that we have seen the outcomes, I want to focus on how we can strengthen the thyroid MDC. One is to continue a prospective data infrastructure and to try to identify ways to automate this data pool to reduce the amount of work. And this will allow us to perform audits and ensure that the quality of our care. Second, to implement routine patient-reported outcomes that focus on us and determine what are the barriers to access, the financial strains, and what is the care experience. This to help us guide the navigation resources and also detect inequalities. Third, to screen for financial toxicity at the intake and find pathways to financial navigation, insurance optimization, and cost communication coaching for clinicians. Fourth, to enhance access for rural and underserved population by expanding telehealth MDC participation and deliver coordinated care in one trip. And finally, prevent schedule-related delays by creating a rapid review pathway to review cases outside the weekly conference. As we close, I want to return to Ms. Whitney's story. When she started this journey, she had a fragmented diagnosis. They had planned the wrong chemotherapy, and no one connected her hypercalcemia, her rate mutation, and her adrenal tumors and lung disease to one unified story. This fragmentation was what the MDC model was designed to prevent. When she came to us, we did what multidisciplinary teams do best. We corrected the diagnosis, we sequenced treatment safely, we avoided unnecessary surgery and effective therapy. Her burden of disease has remarkable shrink in her 3-month scans after being on the right therapy. Our outcomes today, faster diagnosis, safer surgical planning, reduced complication, better long-term survival, there are not abstract metrics. They are the reason patients like Ms. Whitney get the right care at the right time. She is the story behind the numbers. She is why we do this work. And she is the best evidence that multidisciplinary care is not a luxury, it's a life-saving. And this is the team behind those results, the ones that make it happen. Connie Sue is our MDCPA, and she is definitely the backbone of this program. Thank you.
So, Dr. Albuja Cruz, I'll start the questions with which is, what is the difference between a clinic organization like this and, let's say, what we used to do before? Surgery and endocrinology clinics are right next door, and we used to just walk patients back and forth between each other occasionally, and they might see an endocrinologist, they might see a surgeon on the same day when they only had an original appointment. How does this program really differentiate those separate episodes of care?
One of the most important things is that the care is coordinated, so it prevents patients having multiple visits at different times. Also, it allows all sit on the table and review the imaging at the same time and call out different findings that may require different interventions, such as fine needle aspiration. And if there is a need for that, that care is not relied for another visit. That is taken care of during the same MDC clinic visit. So the patient, by the end of the day, has a full diagnosis and a full plan.
Anybody have a question from the audience? Dr. Miller first.
It seems like a lot of what you're describing was you were changing the interpretation from pathology from the outside. Do you want to elaborate on that a little more? It seems like you were making calls that maybe they weren't willing to make.
Yeah, I think that is one of the findings while reviewing this data set, is that our pathologists changed the Bethesda classification of the thyroid nodules. Most of those changes are clinically not significant when they change it for suspicious to thyroid cancer, or indeterminate thyroid nodule in AOS category to follicular neoplasm category. That truly clinically doesn't impact the patient's care. The most important thing is when they downgrade it to a benign thyroid nodule, because that definitely represents the need for no surgery. So I think that is the impact of the review of cytology. And probably the most impactful thing in our MDC is the review of the imaging. And the review of the imaging in our clinic is not done by radiologists. It's actually done by our endocrinologists, which shows the importance of an eye that is expert on seeing this disease, and they're recognizing which of those findings are truly finding that needs a biopsy versus which are don't. And what is incredible about the MDC is some of these ultrasound findings have completely changed the diagnosis of patients, like recognizing lymphoma on the thyroid rather than cancer, and changing completely the course of those patients.
Dr. Robinson.
Albuja Cruz, thank you. That was excellent. I don't think you have to convince anybody that the multidisciplinary clinic is better, but I guess what you'd have to convince me is, could you expand this to all 16 hospitals in the UC Health system? Like, shouldn't all patients that are being managed in this system get the care that you're offering? And I'm just going to give you one example. So we're trying to make better decisions for frail older adults, and we have a multidisciplinary preoperative committee. And so now all of a sudden MCR is joining us, and then Memorial wants to join us too. We're actually finding it's very cumbersome and it's too many pages. Like, we're finding there's logistical challenges to that. But I wonder, could you expand your program to include more hospitals in this hospital?
Yeah, I think that that is also an important part of this multidisciplinary component, and not necessarily through patients, but through the MDC reviews. We have started creating these collaborations, and a lot of the patients that are reviewed are from our sister institutions, and those physicians participate within this conference. And I think that enhancing the care of the patients with telehealth so they can stay with those physicians if the expertise is there is so important, because you also help expanding their knowledge and also kind of standardizing the care amongst UC Health.
Any other questions? Thanks very much. So we're going to